We can't hear you. No, you sound like a mouse almost, like a cartoon.
Speak and pause. Do you hear a replay? All right. Is that better?
Yes.
Yes.
Yeah. Okay. I don't sound like a chipmunk anymore. That's good. You weren't gonna sit there and listen to a chipmunk give you a lecture today? What's wrong with you people? Where's your sense of adventure? We would need an interpreter, right? So we'll let a few more people in here. Your quiz today is quiz 3. You're gonna find it under your course syllabus, February 9th. There are 15 questions today, some of which are math. So you're going to get a little extra time today. You have up to 30 minutes to finish your quiz. So go ahead and get ready to sign in. Question is did I publish the quiz? Okay, you should be able to see it now. If you tried to see it and you couldn't, go ahead and get out of the syllabus and go back in. You should be able to see it now.
Professor, did you say under summary?
Yes, go under course summary. Underneath your written syllabus, you should see all the dates there. And on February 9th, there's quiz 3. Okay, I have 3 Shamari Bings here. You could change your name in the list, please. If you just click on your name, it will, or hit more, it'll let you change your name or rename. So I know who's actually here. Conte's here. Haven't given you the access code yet, Heather. I'm trying to get everybody in and ready to go. I do need your cameras on for the quiz, please.
We're on Canvas.
We're on Canvas.
I have a question. Do we have online, on campus lab this week, or is it
No,
next week?
that's next week.
Next week.
We're virtual today.
Okay.
So we're don't have to deal with the snow today. No guarantee there won't be snow next week, but today we've dodged a bullet. All right. I need some cameras on before we get started. There's Davina, Jessica, Michaela, and Anatu. Honey, you can't hear anything at all? You want quiz 3 on February 9th. Well, Jessica, if you can't take the quiz, you can't take the quiz. There's nothing I can do about that. Quiz 3 does have an access code. So you're not in the right quiz, DeConte. Okay, is everybody ready? The access code is nurse 2020, all lowercase, NURSE 2020, no space. Put all your books away, no books. Good morning, Mrs. Novak.
Officer, what was the access code again? I'm sorry.
The access code is nurse, NURSE 2020, all lowercase, no space. Quiz 3, 2020, nurse 2020.
Are we on break? I'm not hearing anything.
No, we're waiting for the people to finish their quiz, which we will be starting class here in just a few seconds, okay? I just have to get some stuff up. Okay, remember your PowerPoints are in your class shell under week 5 readings. So you can pull those up and follow along with those. We're doing chapters 18, 19, and 20 today. So looking at chapters 18, 19, and 20, what do you think the overall NCLEX theme is going to be today?
Patient care?
Patient care, but specifically for your NCLEX, remember those big broad categories we were talking about? And then moving forward towards the NCLEX.
Infection control and safety.
Infection control and safety, those are very good ideas. Let's see what the NCLEX has to say. Slow and dirt today. Come on. So last week we were talking about coordinating care. Today we are talking about safety and infection control, specifically accident, error, and injury prevention, and not only injury to the patient, but injury to you. Ergonomic principles, that's for you. Basic care and comfort, when we're talking about mobility and hygiene and ADLs and things like that. Okay, so you guys understand what I'm talking about for NCLEX, NCLEX categories?
Can you repeat that again? And what chapters did you say?
Chapter 18, 19, and 20. And what our focus would be for NCLEX is going to be safety and infection control and basic care and comfort. Okay, so chapter 18 is about safe lifting, moving, and positioning patients. Why do you think that's important?
So no one gets hurt?
So no one gets hurt, you or the patient, right? And it's very important that we have a patient in a very comfortable and safe position so that they do not end up with contractures or skin breakdown or pain, okay? So we know a few things about our musculoskeletal system. You know that we have bones, we have joints, which are the union of the two bones. And we know that you have little sacs between the two bones that meet at the joint, and those are called bursa. And those protect the joint so that it's like a pillow in between the two joints so they don't rub against each other. That's the problem with arthritis, osteoarthritis, is that bursa has gone, the cartilage has worn away, and the bones are rubbing on bone. Okay, can you guys see that? You see the PowerPoint?
Yes, ma'am.
Okay, so your skeletal muscles, obviously, those are what help you move. They are connected to the bones through tendons and ligaments. Tendon is muscle to bone, ligament is bone to cartilage. And then your cartilage is that connective tissue in between that's also acting as a cushion. So your bones give you scaffolding. They support everything in your body. They give shape to your body and support to your internal organs and your skin. And the ligaments and tendons allow your joints to move and be flexible so that you can move in different positions. Without tendons and ligaments, you'd be like stiff. You wouldn't be able to move anything because there's nothing to pull and push on that joint, right? Okay, muscles are stretched, they're stimulated by the nervous system, which is basically an electrical system. And the nervous system tells some muscles to stretch and some muscles to flex. That's how you get your movement. And they also stabilize the joints so that they don't pop out of place. Muscles produce heat, so if you're really cold, you move around and you get that heat built up and you get a little warmer, and they maintain posture. So this is very important. You will see these questions many times about changes that occur with aging. Okay, every test, you'll see it in fundamentals, you'll see it in med surg, you're going to see it in the NCLEX. All right. So as we age, bone mass may be lost. We may lose bone mass because of osteoporosis. Osteoporosis is a condition where the calcium leaves the bones and the bones become brittle. Okay. And so they break very, very easily. They can break before the fall. In fact, they can cause the fall. If your femur breaks while you're walking, you're going to fall. Okay, it's not the fall that causes the femur break, it's the femur break that causes the fall. And this is most severe in women. Loss of bone density predisposes the elderly to fractures. We lose muscle cells, and those get replaced, unfortunately, by fat cells. Your muscle fibers, the elasticity decreases and your flexibility gets limited. So, if you're not moving those joints enough, you're going to lose the movement in the joint. And then as the joint motion decreases, it limits your mobility. Okay. Everybody got that? Very important points. So, body movement for nurses. One of the most common injuries in healthcare is lower back strain. It's killed many a career, and you're working too hard to lose your career because you can't move, right? So, first off, whenever possible, get help. Do not tell me that there is no help available. Somewhere in that building, there is somebody to help you. You have to form these relationships, okay? If the patient is able to help, ask them to help. If they can push with their feet, that makes it easier on you. If they can pull up on a trapeze, if they can hold on to the side rail when they're rolling over, there are ways that they can help you. The only patients that cannot help you are those that are totally mobility impaired, all right? And when you are moving anything, you want to use your big muscles, your thighs, your arms, your legs, rather than your back muscles. And we want a wide base of support. That's very important. Okay, just like a triangle, you need a large base of support down here so that this part doesn't fall over, right? You need to provide stability for movement. So your feet will be approximately shoulder width apart. I'm going to use the greatest number of muscles possible. And when we move, we want smooth, coordinated movements, no jerking, okay? You know, this is where people get hurt when they reach or they grab for something and it's not in that smooth, coordinated movement, all right? When you are picking anything up or when you're moving a patient, you need to cuddle your spine, and you cuddle your spine with your abdominal muscles and your glutes. So you want to suck in your abdominals and tuck up your glutes. Your glutes are your butt, all right? So you suck it and tuck it, and that kind of cradles your spine and keeps it from being able to walk, you know, move sideways, but you really don't want that spine moving like this, right? You want it all to move in one motion. So suck it and tuck it and cradle your spine to protect your spine. Keep loads close to your body. So if you pick up your book right now, everybody pick up your book and hold it out here, okay? See how far away I am from my body? Let's hold it out here. And just keep holding it. It's getting heavy. Yeah. Definitely getting heavy for me because I've lost all kinds of muscle in my arm. Now, take that book and pull it in towards your chest. That same book that was so heavy when you had it out here is now lighter, isn't it? And easier to move. Okay? This is why you want to keep your loads close to your body. You move your patient over closer to you in bed so that you are not reaching over or doing anything out here. You want to be close, all right? You want to keep the loads near your center of gravity. And we want to use pull and pivot, smooth, coordinated movements, no jerking or sudden pulling movements. You guys are going to practice this in lab next week. So you see how he's using his leg muscles here? Okay, he's not bent over to pick up that box. He has squatted down to pick up that box. He's using all those big muscles here in his legs to push him back up and to keep his back straight. Okay, so when we're moving and lifting patients, we want to keep our elbows close to our body, all right? And we want to move the bed up so that it is at waist level. Okay, you shouldn't have to reach over or bend over to take care of your patient. They should be right here, okay? Put the bed at waist level, okay? Or if you're trying to move from a stretcher to a bed, make sure they're even, okay? Keep them at the same height and keep your load near your center of gravity. And remember, it takes less effort to pull something towards you than it does to push away. So if you can, you know, turn somebody by grabbing the sheet and pulling them towards you, it's much easier on you and your back. Your arms are levers when you're pulling the patient towards you. You can always lock your elbows and rock back to pull back on the patient. Okay, principles for body movements for patients. All right, so we've talked about how to protect you. Now, how are we going to protect your patient? There's two basic principles in here. Remember these. You need to maintain correct anatomic position, and you need to change positions frequently. You don't want your patient lying in bed all cattywampered up, right? You want them lying with their back straight and their extremities where they're supposed to be. Okay, you don't want them, you know, just kind of thrown in bed and like sideways and all kinds of different ways. No twists, no turns. Improper alignment can interfere with your circulation, which we know can lead to pressure ulcers, cause muscle cramps and possible contractures. Contractures are when the tendon shortens. Okay, so if I am constantly holding my hand like this, all right, if I have no less muscle tone in this wrist here and I can't hold my hand up independently, this tendon right here in my wrist is going to get shorter. Okay, because we're not using it. So then when I try to do this, I can't get it to move up because the tendon has kind of locked in place here. That's a contracture. Okay, you can get contractures in your fingers, in your wrists, in your feet. You can have contractures in your hips, in your knees, anywhere there's tendons, you can have a contracture. This is why we have to stretch and move our patients around a little bit. Okay. And then the last thing is fluid collection in the lungs. You know, your body's just a big sack of water, right? And water is going to follow gravity. And if they're continually laying on their back, that water is going to go down and it's going to filter into their lungs. Okay. We call that hypostatic pneumonia. So we need to move our patients around and encourage coughing and deep breathing in order to prevent the fluid collection in the lungs. Okay, so correct body alignment. You like to see people with their shoulders and their hips and their ankles aligned, right? Back is straight, abdominal muscles tucked in, head up, eyes straight ahead. We're not hunched over, okay? So if your patient is standing up, we'd like to see this. Now, you're not always going to see this, right? A lot of times you're going to see people who are hunched over looking at the floor all the time. But that's something that we want to avoid if they walk in the building, then they should be able to walk out of the building. Okay, we're not going to allow contractures to happen while they're in our care. Okay, when you have your patient sitting in a chair or the wheelchair, okay, again, we want correct sitting body alignment. Ear, shoulder, hip, all in one line. Is your ear, shoulder, and hip in all one line right now? No? Well, put it there. See how it feels. Pull your shoulders back a little bit. Sit up straight. All right, doesn't that feel different? Does it feel better? Less stress on your muscles, right? So yes, the nuns were right. Sitting up straight does help. So, and then we have pressure ulcers, and we're going to talk about these more in chapter 19. But pressure ulcers occur when there's pressure on the skin that causes the blood flow to that area to stop. So if you think about your elbow is a pretty bony prominence, right? And you have skin over it. If you're leaning on your elbow for a long time, when you stop leaning on your elbow is going to be red, right? So that means that we're having a problem with keeping our blood flow to that elbow because we're leaning on it. All right. So think about the ischial spines in somebody's butt. Those are your sit-upon bones. Or the coccyx if you're sitting back and you're kind of slouched down. You're now sitting on your coccyx, not on your sit-upon bones or your ischial spines. Okay. So when the pressure between the bone and the surface causes the blood to stop to the skin, that's when we have skin breakdown. Okay. It can also be caused by shearing, and shearing is a force that if you try to drag your patient up in bed, sometimes if you're dragging, then the part that's on the sheet is going to stay put and the part that's above it, so you have your dermis down here and your subcutaneous here, is going to move and it's going to shear between the layers of skin, and that's going to cause bleeding, bruising, and it's going to cause skin breakdown. So shearing is also a major reason people get skin breakdown. Come on. So think about your nursing process. What do we start with? We always start with assessment, right? So when you're looking at your patient, when you first lay your eyes on them, what are you going to be looking at?
The way they breathe.
Okay, but we're talking about positioning now. What are you going to look at?
How they're sitting or standing.
Right, what's their posture look like? How are they standing? What's their head position? You know, if their head's over here, that could be a contraction too, right? If it's not midline, or if it's down here, right? You're going to assess them sitting and look for symmetry. What does symmetry mean?
The same on both sides.
Same on both sides, right? You know, I have one here. I should not see the ear over here, right? Look at their ability to ambulate. It is very, very important to prevent falls, that you know how much assistance the patient needs to ambulate. Do they need an assistive device? Do they need standby assist? Do they need a one-person assist? Okay. Observe them walking. All this will give you an idea how their body is being put together today. Because remember, it changes as you get older. Some of the nursing diagnoses that we use for people who have problems with their posture and their positioning: risk for injury. What kind of injury are we risking? We say risk for injury. What are we looking at to get injured if we're not positioning them properly?
Skin breakdown.
Skin breakdown, yes. What else?
Bed sores.
Bed sores, okay.
If they're older, you can do a broken
about
bone,
this?
right?
Pardon?
If they're older, it's easy to break bones, right?
They can break bones, yes. And what's this called?
Contractures.
Contractures. Those are all injuries that we don't want to happen. So that could be a common nursing diagnosis we would use. Impaired physical mobility. Okay, obviously they can't move themselves, it's impaired, right? Risk for impaired skin integrity because of the immobility. And then impaired walking. If they're unsteady, if they have an unsteady gait, if they have problems keeping their balance, that's impaired walking. Okay, so now we're going to have to plan. We're going to have our goals. So we're going to decide how to change the patient's position. Some patients are tricky. They really are, because of what they come to you as, what contractures they have, what issues they have, okay? And then whether you can delegate that task to an assistive personnel. If you have a patient who is extremely fragile because of osteoporosis or extreme old age, you may not want your assistive personnel moving them around. You might want to be in the room when they move them around. I once had a assistive personnel break somebody's leg because they were trying to walk them too fast. Okay, and the femur just broke. Severe osteoporosis. Okay, and then when we're talking about the home setting, we also have to plan for care for the patient. If we are sending that patient home, can they get in and out of bed by themselves? Is there somebody there to help them get in and out of bed? Is there somebody who's able to turn them if they can't turn themselves? Because if you just send somebody home to put them in a hospital bed and nobody's going to be able to move them, they're going to come back to you with an ulcer this big on their butt, okay? Which is not what we want. So we have to make sure we're safe sending them home too. Expected outcomes, okay? Obviously, we're not going to expect any injuries, all right? We want them to get to their former level of mobility within 6 months. And this is for people who have had an injury or have had surgery. We want them back to normal or back to what they were before the injury within 6 months. That's a long-term goal, right? Skin integrity will remain intact while the patient is on bed rest. The patient will not experience any injury while ambulating, or the patient should have full range of motion exercises actively or passively performed several times a day. All right. These are things that we want to see happen. That's our plan, right? So when moving a patient, it's important to use proper body mechanics. Which of the following is not proper body mechanics?
Keeping your
No.
feet together.
Right. What do we have to do with our feet?
Put them shoulder width apart.
Shoulder width apart. We want a wide base of support, so they should not be together. Okay. Leanne is teaching her patient's husband how to lift his wife safely. Which of the following is true regarding lifting the elderly? What is true?
Four.
4 is true, right? Because we know as the body ages, there are many changes. And that we don't increase muscle mass as we age, we decrease muscle mass. And whatever items that you can lift in your youth should be lifted in later years, not necessarily because we're losing muscle mass. So number 4 is correct. Joint motion may decrease, limiting mobility. Okay, go ahead and take a 10-minute break. So come back at 10:15 and we will get back into lifting, moving, and positioning. All right, time to come back and everybody get your cameras turned back on. Still lots of cameras off. Come on. So Jessica, Charles, DeConte, Davina, Michaela, you need to get your cameras on. Okay, that's better. Okay, so we've talked about assessment, we've talked about nursing diagnosis, we've talked about plan. So what's the next thing?
Implement.
Implementation, okay? So now we're going to talk about actually taking care of our patient, putting our hands on our patients, okay? There are 4 objectives to proper positioning. First of all, it gives comfort to the patient, okay? It relieves pressure on bony prominences and decreases their risk of developing bed sores. It prevents contractures, deformities, and respiratory problems, and it improves circulation. Okay, 4 objectives. Okay. So there are common positions that we use, and there you might even see orders for these types of positions. Whenever we say supine, we mean that somebody is laying on their back, okay? They're on their back. And so now, instead of being flat on their back, we want to put their head up. So Fowler's position is meaning we're laying supine, but our head of the bed is 60 to 90 degrees. Okay? So they're basically almost, there we go, almost sitting straight up down here. Okay? Down here. So what would we use this position for?
To feed them, right?
To feed them, right? They can't eat laying on their stomach or on their flat on their back, right?
Mm-hmm.
So we gotta make sure they're up to eat. What else?
If we want to do any like oral care.
Oral care on a conscious patient, yes.
Giving medication.
Giving medication, yes. So many people forget to put the head of the bed up when they're giving medication. You know, if you're making them swallow something, that's the same as if you're giving them lunch, right? If somebody is having respiratory difficulty, you want to put them up in a Fowler's position because that's going to allow gravity to help the lungs expand. Okay. So those are some reasons we have people in Fowler's position. A semi-Fowler position is the head of the bed is 30 to 60 degrees. Okay, so it's kind of mid-level. Okay, and you can ratchet the knees a little bit just to keep them from sliding down when they're in this. But you got to make sure they're in correct alignment. See the pillows under the arms to keep those hands from flopping forward, etc. So 60 to 90 degrees, 30 to 60 degrees, and then low Fowler is 15 to 30 degrees. Okay, so their head of the bed is barely up. But if you have somebody who is on a continuous tube feed, then we want to make sure that their head of their bed is at least at 30 degrees. Otherwise, if they're laying flat, the tube feeding they were pumping into their stomach could regurgitate up into their throat, and then they could breathe it into their lungs and choke. Okay, so Fowlers, 60 to 90, semi-fowlers, 30 to 60, low fowlers, 15 to 30. Remember those numbers. Okay, some variations on that position. We have our dorsal recumbent position. This is where we're laying flat on our back, knees are flexed, feet flat on the bed. And this is used for many procedures and examinations. What could you think it could be used for? It's a picture on page 273 in your book, or it looks like this. So why would we put a patient in this position?
Pelvic exam.
Pelvic exam, yes. Why else?
Pap smear.
Say again.
Pap smear.
Pap smear, okay. It's actually a better position for pelvic exam and pap smear coming up. What about pericare? Would this make it easier to reach the perineum? What about putting in a Foley? Okay, that's what we use this position for cleaning, for examining the peri area, for putting in a Foley, anything like that. The next slide is what we would use for a pelvic exam. Okay, this is called the lithotomy position. It is similar to your dorsal recumbent, except our legs, instead of being feet flat on the bed, they're up in a stirrup. And this is what they use for PAPs and for pelvic exams in the gynecological world. So then there are other positions that you can be in. You can be a side lying position. You can put your patient on their side. We just want to make sure that when we put our patient on the side, we do not want them lying directly on their greater trochanter or their hip bone, okay? Because then they will have a problem with skin breakdown there. Sometimes we do a oblique side lying. So we kind of, instead of having them, and I am on page 275 in your book. Your side lying position's the picture on the top where they're directly on their side. Notice the pillow between their legs to keep their knees from touching and to keep their hips in alignment. Your side lying oblique is where you're got them on their hip, but you kind of pull their shoulders back and they're sort of half on their back and half on their shoulder, on their hip or on their side. Okay, see the pillows supporting the shoulder. See the pillow between the legs. Anytime you move someone sideways, we need to put a pillow between their legs. Okay, and then the last one is the Sims position. Sims is a good position that we use for any kind of rectal exam, inserting enemas, inserting suppositories, putting in a rectal tube, anything that has to do with the rectum. This Sims position is a very good position to be in. There it is, okay? So they're basically, they're almost prone. They're almost on their stomach. Okay, this leg kind of keeps them a little bit on their side, but it gives you a lot of area to work in here, okay? So common positions you may have when you're prone. Prone means we're laying them face down. It's not a comfortable position, okay? We often use it for patients with spinal cord injury, just to get them off their back. We will flip them over on their stomach. Face down, usually, unless if they have some kind of neck injury, they're going to be all the way face down and they'll be in a special bed. Like anybody been on a massage bed where you have the donut where your face goes through the hole there so you can breathe? Okay, we can do that with our beds that we're putting people prone in. But usually we're going to have them turn their head to the side if they can tolerate that. Okay, And a variation of the prone position is they're lying on their stomach, but now they bring their knees up to their chest with their elbows resting on the bed. You can also use this for rectal examinations or inserting suppositories or tubes or whatever you need to do there. So there's our prone position. Notice we have a pillow here under the hips so that we don't end up with a dip here. There's a pillow under the feet to keep them in position. And here's your knee chest position. So we use devices to position our people and keep them in the place you want them to be. Okay. A lot of times if you're trying to get somebody to lay on their side or, you know, just a little bit lateral, if you don't put something behind their back, they're going to fall right back over on their back. Okay. So we use pillows to support body and extremities. We want to maintain dorsiflexion. What is dorsiflexion? What is dorsiflexion? Well, flexion means the joint is flexed, right? So dorsiflexion means that the dorsal side of your foot is up. Okay, so dorsiflexion means that when you're laying in bed, your feet are up and not dropping down or over to the side, rotated out. They're up. And you need to do that because if you don't maintain dorsiflexion on somebody who is immobile, then here again, that Achilles tendon in the back of your leg is going to get shorter and the foot's going to drop. And when the foot drops and the Achilles tendon is shorter, it's very difficult to get that heel down on the floor if you're ever going to stand this person up. Sometimes you may experience this if you wear high heels for a long time. Okay, or if you wear high heels every day, when you go to put on a pair of sneakers or tennis shoes or walking shoes and your heel is flat, you get that pain in the back of your leg. That's the same thing, that your Achilles tendon has kind of shortened up a little bit and now you have to stretch it out again. To maintain dorsiflexion, we can use boots or splints, but we can also use high top sneakers. Okay, if you put a pair of high tops on them, their feet are not going to be able to drop. Footboards are okay, but you have to watch the skin and the pressure. And then trochanter rolls, we use trochanter rolls to keep the leg from rotating back out. Okay, so you can either put it from the hip down or from the neck down to keep the leg from rolling outwards.
The way that we position their legs, can that help with the blood pressure too? Like I know they say sometimes I get like really low blood pressure and they told me if I prop my legs up for a little bit, like it might help.
Right. Yes, if you need to get higher blood pressure, you always put the feet up higher than the heart and the blood comes back. Your blood moves in your veins basically by gravity. Okay, the heart's pumping in the artery and then the veins just kind of get pushed up when the blood comes out of the artery into the vein. Okay, so if we can use gravity to get the blood back up towards the heart, we can do that. Moving a patient up in bed, you know there's many ways to do it, but never try and do it yourself. If your patient can help you and pick their butt up and push with their feet, great. If not, we need at least 2 people being on opposite sides of the bed and hopefully using a sheet to move that patient up in bed. What happens if we don't pick their butt up? What happens if you drag them up in bed?
They could fall through.
They could fall through. What else?
Skin
Talked
therapy.
about it about a half hour ago with skin.
Skin therapy.
Break the skin.
You can break the skin, and what's that called?
Patient injury.
It is a patient injury, but what's it called?
Skin tear.
Shear.
Sure.
Shear, not a tear. It's skin shear. Remember when the bottom stays put and the top goes and it shears the subcutaneous from the cutaneous layer? And now we've disrupted the blood flow to that area because your blood flows in your subcutaneous. Okay? So if we're dragging our patient, we are putting him at huge risk for shearing. Here's an item, a trapeze bar that you can put at the head of the bed. If your patient is able to grab onto that and pick themselves up a little bit and push themselves, pull themselves up in bed, that's wonderful. Okay, we already talked about that one. Log rolling. You look in your book on page 280, okay? Log rolling is when we're turning the patient as a single unit. That means that the hips, the spine, the neck, the shoulders all move at the same time. All right? So it's a technique we use for people who have had spinal cord injury or who have back surgery because you don't want that spine twisting in any way. So you're going to use 2 or 3 people at least in order to move that patient as one unit. So here it is with 3 people, one on the other side of the bed. He's pulling, that's the easier part, right? And the ladies are pushing and positioning, but everything moves at once. You can also do it where you're all on one side of the bed and you all pull towards you. But the whole goal is that this body stays straight. Keep it straight. Lifting and transferring, if a patient can transfer independently, fantastic. But a lot of our patients require levels of assistance. It could be a standby assist. It could be one person hands-on assist. It could be a one person total assist. Okay, there are different levels of assisting. But you want to make sure you have assessed your patient properly so you know what level they're supposed to be at. Okay. When a patient is getting out of bed, we always dangle the patient at the bedside. Dangle means we're sitting on the side of the bed with the feet down. And what are we trying to prevent here?
Fall.
We're trying to prevent a fall because what happens when you sit up?
Your blood.
You get lightheaded.
You get lightheaded. If you've been in bed for a while and you sit up quickly, you're going to get lightheaded. Okay, so we're going to put them on the side of the bed and let them dangle for a minute or two to see if they get dizzy or nauseous. Okay, to see if their blood pressure is dropping. Remember, blood pressure is going to be at its highest level when you're laying flat. Okay, once you sit up, your blood pressure is going to adjust and it's going to drop a little bit. A little bit's fine. If it drops more than 20 millimeters of mercury, though, then we have orthostatic hypotension. Okay, and when you sit to stand, your blood pressure is going to drop a little bit more. And if it drops more than 20, then we have orthostatic hypotension. Normally, you can do this all in one sweep and your blood pressure can adjust itself and you're going to be fine. You're not going to be dizzy. But if your patient has been in bed for a while, they're on medications, they've had surgery, you want to do this. You want to make sure that you dangle your patient. If you're going to transfer to a wheelchair or a gurney, make sure you check the brakes. The brakes have to be engaged before you attempt to transfer the patient. And then if you're using a stretcher, if you're going to have somebody who's unable to sit up in a wheelchair, you're going to use a stretcher to transport them. And then lift equipment like a Hoyer lift, a stand-up lift, the kind of equipment that assists the patient so that you don't have to do all the work. Okay, but you always need 2 people in place to use a lift. Okay, I've had lift slings fail. I've had patients fall. You need 2 people in there. So you're going to determine how much help your patient's going to need. Get that help. Make sure the wheels are locked. Use a transfer device when possible. So a transfer device could be a sit-to-stand lift. It can be a bed board or a sliding board to help them get into the wheelchair. Okay. Make sure you dangle the patients before you ambulate or get them up. And you always use a gait belt when you are ambulating or transferring your patient. That's what you can do while they're dangling. You can put the gait belt on them. So we can transfer using polar lift sheets, mechanical lifts, roller boards, slide boards, or gait belts. So Dr. Tingle called the unit and asked the nurse to put his patient in Fowler's position. Which of the following correctly describes Fowler's position?
2.
2.
Very good. 60 to 90 degrees. Good job. Okay, Dr. Tingle's back now. He says, oh, I didn't mean that. Put him in the prone position. What's prone position?
4.
That is one of the positions you can get into when you're in prone. But what is prone? Just prone by itself.
3.
3 on their abdomen. Okay. We can do the knee chest while you're prone, but that's not a prone position. Which of the following is not a positioning device? Okay. We did not
Blanket.
mention this. Blankets. Blankets are not positioning devices. They're generally not stiff enough to keep your patient where they need to be. Okay. So that is chapter 18. Any questions? Any questions on chapter 18? What do you think test questions are going to look like from chapter 18?
About different positions that you can position a patient or resident in their bed or wheelchair.
Absolutely. What else?
Skin breakdown.
Skin breakdown. Yes, I expect a few skin breakdown questions on the next test.
Positioning.
Positioning. Yes. What would it look like in a Sims position? What's it going to look like in a knee chest position? What do we use these positions for? Good job. Okay. So we're going to move into chapter 19 now. And this is more about skin and how to prevent injury. It's talking a little bit about hygiene. And remember, when we're talking about hygiene, I know some of you are already aides and you give baths every day. Now we're going to be doing this as a nurse. And as a nurse, you're going to have a whole different focus. Yes, you want to get your patient clean, but you're also going to be assessing the whole time you're doing that. Okay? Okay, so chapter 20. Patient, no, that's not the right one. I wanted 19. Never mind. Let me go back and get 19. So assisting with hygiene, personal care, skin care, and prevention of pressure ulcers. So remember, we're looking at safety and security and all that here. Care and comfort. All right. So who knows what the layers of skin are?
Epidermis,
Mm-hmm.
dermis,
Epidermis, dermis, what's below the dermis?
A hypodermis.
The hypodermis, yes. Subcutaneous, right? So when we're looking at your skin, the top of your skin is the epidermis, okay? And the epidermis does not have any blood vessels in it, okay? It does have the melanocytes in it that determines your skin color. There's really very little nerve endings in the epithelial tissue, okay? The nerve endings are a little bit deeper, all right? So this is the top layer. The next layer, the second main layer, is the dermis. And in the dermis, you have your strong connective tissue, you have your hair follicles, you have capillaries, you have your sweat glands, okay? We have these things are the sweat glands. All right, this has the elasticity in it. And then the lower layer is your subcutaneous tissue where you have your blood vessels and the adipose tissue. All right. So it's important to know this because if we have a wound, we want to know how deep it's going. And if it goes so deep, what is affected by that?
your nerve,
Yeah. Say again.
your nerves,
Your nerves are basically ending up here in just above the dermis and right below the epidermis. Okay.
The dermis.
Yeah. So your mucous membranes, although not strictly part of the integumentary system, they do prevent, remember, skin is your first line of defense against pathogen entering the body. Your mucous membranes are your first line of defense against pathogens that come into your body and trying to get into your cells, okay? They line cavities or passageways of the body that open to the outside. So your mouth has mucous membranes in it because you have a passage to the outside. Your rectum has mucous membrane in it because that is coming from the inside out. It is epithelial tissue over a deeper layer of connective tissue, and it protects against bacterial invasion. Lysosomes are included in the secretions that you do from your mucous membranes, okay? And that kind of cuts down on the bacteria. They also absorb fluids and electrolytes, and you will see that sometimes we can give medication through the mucous membranes. All right. Protection is the function of the skin. First line of defense against bacteria and other organisms. It also protects against thermal, chemical, and mechanical injury. All right. Intact skin is very important. Your sebaceous glands make the skin waterproof. Okay. Your skin contains sensory organs for touch, pain, heat, cold. And your skin helps regulate your temperature because when you get really hot, your blood vessels will open up so that the blood goes past it and gives off heat, okay? It can activate or inactivate your sweat glands because we know when we're hot, we sweat, and that helps cool us off through convection. And then excretion and secretion. Your sweat glands help maintain your homeostasis of fluid and electrolytes. They also excrete and secrete nitrogen waste. Okay. The sweat glands in your axilla and your external genitalia secrete fatty acids and proteins to help protect against bacteria. Sebum lubricates the skin and hair and keeps things pliable and elastic. It also decreases heat loss and it decreases bacterial growth. So all these things that the skin excretes or secretes is to keep you safe. So here we go. Skin changes occurring with aging, just like with the musculoskeletal system. Your skin is affected by aging also. You need to remember these, okay? You lose elastic fibers. That's what causes your skin to wrinkle and sag, because you lose that elasticity. If you think of a baby and you see how firm and plump their hands are and their feet are, okay? They have lots of elasticity there. Well, as you get older, you lose that elasticity, and you'll notice the hands give somebody's age away, because you can see where they've lost all the tissue underneath and it's basically just skin and bones, and there's no elasticity, okay? Skin becomes thinner, fragile, and slower to heal as you get older, okay? So if it's thinner, it's easier to tear, easier to break down. We have decreased sebaceous activity, and we just talked about all those things the sebaceous glands do for us, right? Leaves your skin dry and itchy, and when you're scratching, you can cause injury to your skin, right? You can get an opening for bacteria if you scratch your skin and you cause bleeding, right? Temperature control is altered because of the decreased sebaceous gland activity and the thin skin. So if you get older, you're going to get colder. And then your hair becomes thinner, grows more slowly, and loses its color from the loss of melanocytes. So that's where gray hair comes from. So, assessment. Hygiene and pressure ulcer risk. Hygiene is proper care of the skin, hair, teeth, and nails that protect the body from infection and disease. Things that affect hygiene practices. Socioeconomic background. You know, if you remember the Maslow theory, if you're fighting for safety and security, hygiene may not be high on your list, right? Just saying. Different cultures view different hygiene practices, or have different hygiene practices. Also, some cultures consider a daily bath and deodorant an essential part of their living. Others say, hey, once a month, once a week. Okay, fine. Okay. So it all depends on what their culture is as far as bathing goes, is what you're going to see when you get your patient. Okay. Ability to perform self-care is a big one with the elderly, because remember, as they get older, they're going to lose their mobility and their flexibility in their joints, and they may not be able to reach all those places they used to reach. Okay. So their hair, their face may be really clean and their hands may be really clean, but if they can't get to their back's not going to be clean. Okay, because they're trying to do things themselves that they can't do. All right. Self-care abilities, depending on the medical condition. If they've had a stroke and they're flaccid on one side now, so now we can't use our left side. We have to do everything with the right hand. We have to get the left hand moving. So those will also affect hygiene. All right, when you are giving your patient a bath, and don't tell me nurses don't give baths, because nurses do give baths. All right, bed baths and showers. This gives you a great opportunity to assess. It's not often you're going to get to see your patient without any clothes on. All right, so you can assess the condition of the patient's skin. You can check those skin folds to see if maybe they're red and itchy and maybe have some yeast. You're looking at their overall physical appearance, because people can hide cachexia or starvation with clothing. We have patients who are anorexic, and if it's not on their records, you don't know, but when you take their shirt off and you can see every rib in their body, then you know that there's a nutritional deficit here because you should have a little bit of meat on your bones, right? Learning needs, mental status. These are things that you're going to be able to pick up on while you're spending time with your patient. Skin and pressure injuries. We already know that that's an interference of local circulation. When it says skin blanches or becomes pale, when I think of blanching, I think of a reddened area that if I push on turns white and then goes back to pink or red. So if I push on my hand, you're not gonna be able to see this, but if I push on my hand, it's gonna turn white and then it's gonna go back to pink. That's blanching, okay? A pressure ulcer will not blanch. It will remain red, it will not turn white, and it will not come back. It will stay the same color. Okay, and if interference or pressure is removed, the skin becomes darker as blood supply returns. But you will notice that if you have a red area and you move the patient off of it and you go back and check it in an hour, half hour, an hour, and now it blanches, you have saved the day. If you had kept them on that side a little longer, we may have ended up with a pressure area. Okay, so you always want to go back and see if that pressure area disappeared or now it's blanching when it wasn't earlier. And keep that in mind when we're talking about positioning your patient. If that area is delicate, then I wouldn't position a patient on it. Okay. Risk factors for pressure areas or pressure injury. I've already talked about immobility. Incontinence keeps the skin wet. Wet skin gets what we call macerated or soggy, okay? And soggy skin can peel off easier. It can cause a pressure area. The other issue with incontinence is that urine is an acid and it can burn their skin. So we need to make sure incontinence care is being done. Diaphoresis, what does that mean? Who knows what diaphoresis means? Never heard that word before?
I haven't.
Okay, diaphoresis means excessively sweaty. So somebody who is having a heart attack, the anxiety, the insult to the body is going to cause the body to sweat, or we call them diaphoretic. Okay, so diaphoresis, people who are excessively sweaty have the same issue with the wet skin, can cause skin breakdown. What kind of nutrition do we need to prevent skin injuries? What do we have to feed our patient? Very good, Alexis and Vanessa. We need protein. We need protein for healthy skin, muscle, and bones, okay? Lowered mental awareness means that they're not going to shift when they're getting uncomfortable. Extreme age, you know, if you have a centurion, somebody who's 99 to 100 years old, remember their skin is thinner, they have less padding in there, less elasticity, they are at high risk for pressure injury. And then edema is where your skin swells because of circulation issues. Okay, so it's like a big balloon. And if you bump that balloon, you're going to tear it open. And then we're going to have, or if we have that balloon sitting in one spot too long, we don't have a good circulation there, we're going to have skin breakdown. So we always need to do a skin assessment for pressure injury on admission. This is important for two things. One, you want to make sure that when they come in, they don't have any skin breakdown so we can get on it right away if they do. And secondly, the way the rules are for pressure areas are a never event or a sentinel event. They should never happen. Okay, so the way it is with pressure areas, If you identify a pressure area on admission, then that pressure area does not belong to you. Okay. Yes, you're going to treat it. Yes, you're going to make sure it doesn't get worse, but you are not the cause of that pressure area. If you miss that pressure area and find it 2 days later, now you are the cause of that pressure area. So we want to make sure we do a thorough skin assessment on all admissions. Okay. And the other thing we have to do is a Braden scale. A Braden scale predicts your pressure area or your pressure sore risk. It's on page 298. Okay. It's checking sensory perception, moisture, activity, mobility, nutrition, and friction and shear. Okay. The lower the number, the higher the risk. So if you can look at the scale at the bottom there, a moderate risk is 13 to 14. All right. The highest you can get on this would be 23. Okay, because there's 5 4s and a 3. So the higher end, we don't have to worry about so much. If we are at a 13 or below, this is when you're going to start thinking about how can I protect the skin. This is where we get the cushions in the wheelchair. We put the gel mats on the beds. We do something to keep their skin from breaking down. We turn them every 2 hours. We get the dietitian involved. You have to start immediately on preventing pressure areas on people who are moderate to high risk. Okay, that's part of your job. So you're going to do the Braden scale on admission. You're going to do it every week for 4 weeks. Then you're going to do it every month. Okay, this is something that is an ongoing piece of objective data that we can use to see if they're getting better or worse. So pressure ulcers are staged, and we never backward stage them. If they started off as a stage 4, they will always be a stage 4. They're just a healing stage 4 as they fill in. Okay. So we have some pictures here. Aren't they fun? These are also in your book on page 299. A stage 1 pressure area is an injury that is not open. Okay. It could be a darker color. It could be red and not blanching. Okay. This is a warning sign that there's tissue damage below the skin. All right. And the goal is to keep that skin from opening up. All right. So pressure here, stage 1, it is a non-open area. It is entirely closed. All right. So you can see around here and around here, we have stage 1s. Okay. Because the skin is not open, it is discolored. A stage 2 pressure area, the skin is open. It's shallow, it's not very deep, it's just into the dermis. All right. You can see here where it's just like basically a skin tear. What you could call a stage 2 would also be a blister, because with a blister, the epidermis is separated from the dermis. So pressure area injury 2, or stage 2 pressure injury, you have the skin separated and it is open. A stage 3 pressure injury is down closer to the subcutaneous. It is deep, generally has some identified ridge on the edge, because you're past the dermis. You're going into the subcutaneous layer here. And you can see this yellow here, that's fat. Okay, so you are through the epidermis and the dermis, and we're getting into the subcutaneous layer. Stage 4, you are past here's your epidermis, here's your dermis, this is your subcutaneous, you are down to the bone. Okay, all the tissue is gone. That is a stage 4. It's all the way past the subcutaneous and it's down. You'll see muscle, you'll see bone. It's not a pretty sight. This right here, this dark leathery skin is called eschar, E-S-C-H-A-R. Okay, it's a buildup of tough necrotic tissue. It could be dry or it could be wet and oozy. All right. We don't know how deep this wound is because we can't see the bottom. So they get staged either as a stage 4 or a unstageable pressure ulcer. The only way to heal this pressure ulcer is to get rid of this eschar. All right. The only way you can get rid of it, because you can't get any treatment to the good skin until you get rid of the dead skin, and that's what this is, dead skin. And then this picture is of a deep tissue injury. It is closed, okay? It is not open. It looks like a big bruise. It's a maroon area. It's a purple area, okay? That means that there's damage below your epidermis here, okay? This one could go all the way to the bone before it opens up. So we have unstageable and we have deep tissue injury. Deep tissue injury is generally intact skin that has discolored, and we're looking at a possible opening and a huge pressure area. So prevention of pressure injuries, number 1, excellent nursing care. You need to be involved with all your patients every day, making sure that they are not developing pressure areas, okay? Make sure they're being turned. Make sure their incontinence care is being done. Make sure that the skin assessments are done when they're supposed to. It is your responsibility to be aware of risk factors of your patient and try to lessen those risk factors, okay? So if you have a patient who has issues with shearing, then we're going to be using a lift sheet to move them. If you're having patients that are having a low Braden scale, we're going to get the gel cushions out and the pressure relieving devices to prevent pressure areas. And then prevention is less time consuming and less expensive than actual doing a pressure ulcer treatment or treating an injury. Okay. Those dressings, well, first of all, it takes a long time to do a dressing change on a pressure ulcer. And then those dressings are very expensive. All right. It's much easier to prevent it than to have it happen and have to treat it. So how do we prevent pressure injuries? Here are some interventions you can use. These should be burned into your soul, okay? Change the patient's position at least every 2 hours. You have to allow circulation to return to the skin. Keep the heels of immobile patients off the bed. Now, that doesn't mean they have to be way up in the air. They only have to be off the bed so that they are not creating pressure between the heel and the mattress, okay? So instead of putting the foot on the pillow, you're going to hang it off the pillow a little bit so that the heels are being floated, okay? Avoid positioning directly on the trochanter. Use a trapeze or lift sheet to change position. Use pressure reducing devices such as foam pads or mattresses. Use pressure reducing devices for patients in wheelchairs. Anybody ever sat in a wheelchair for a long time? And nobody ever had that pleasure? You should try it sometime. Wheelchairs are extremely uncomfortable. There is no padding on a wheelchair. Okay? We need to put some padding between our patient and the wheelchair. Shift weight at least once an hour, preferably every 15 minutes. And I know that you guys haven't sat in the exact same position for the last 3 hours, have you? Or 2 hours. You've been moving around. You've been sitting. Some of you have been up walking. I've seen you. Okay. You have to remind your patients to move around a little. And then we want to restore circulation by rubbing around a reddened area, never directly on the reddened area. Okay. We can try and restore the circulation by rubbing around that area and see if we can't get the blood flowing again, but never directly on the red area. We want to make sure we give incontinence care promptly. If your patient has a cast or a brace, we need to make sure that we're not getting mechanical injuries from those. Braces usually can be loosened up or taken off once a day to look at the skin. With a cast, you gotta make sure that they're not putting their heel on the bed. They're not causing a pressure injury on their heel by, laying the cast directly on something. Make sure that their foot is elevated and their cast is floating. Avoid skin injury that's caused by friction and shear, and we can do that by lifting our patient, not dragging. And then adequate nutrition and hydration is very key. So anytime you have anybody who is at high risk for pressure injuries, we got to make sure that we have the dietitians involved, that we give them adequate nutrition and hydration. The most effective treatment is a team approach. It's going to be the family, the patient, the doctor, the nurses, the skin team. Everybody's going to be in on this, okay? And the initial care for debriding or for a pressure injury is we got to get that eschar off the top. We got to get it cleaned out, okay? Once it's clean, then we can go ahead and treat the wound. So part of your treatment at the beginning is going to be cleaning, whether we use an enzymatic cream, or the doctor comes in and uses the scalpel and cuts away the dead tissue. And then we're going to cleanse the wound and we're going to put a dressing on it. And there are many, many, many dressings out there that we can use for healing pressure ulcers. Some of them work magic, okay? If the injury is infected, we need to use some antibiotic therapy. Don't forget that silver is a natural antibiotic, and you will see a lot of dressings infused with silver now to decrease the bioburden of the wound. And some injuries need to have surgery to repair them, that they will fill in so far, but then stop. And so they have to put a skin graft over them to keep them, to get that intact skin back in there. Your nursing diagnoses that go along with hygiene and skin breakdown, okay? Pain is some of those wounds can be very painful. Chronic low self-esteem, chronic pain can affect their hygiene practices. Dressing self-care deficits, if they can't do it themselves, it's going to be a problem. Imbalanced nutrition, less than body requirements, especially protein. Impaired physical mobility, impaired skin integrity, ineffective peripheral tissue perfusion, that's how we get skin breakdown, and at risk for impaired skin integrity. Okay, a couple more slides and we'll take a break. Which of the following is not a function of the integumentary system?
Four.
No, we can do excretion and secretion. Remember the sebaceous glands? I'm seeing a lot of two.
Oh,
So those of you who are putting 2 in the chat, you are correct. The skin does not provide color. The melanocytes that are in the skin provide the color. Justin has a patient in a long-term care facility with a pressure injury. It can be described as a full thickness skin loss that looks like a deep crater and extends to the fascia, which is the covering over the muscle. Subcutaneous tissue is damaged. What stage is this injury?
Stage 3.
Yes, it is a stage 3, and the clue here is the subcutaneous tissue is damaged. The stage 2 does not get down into the subcutaneous tissue. It's just in the dermis. Okay, take a 10-minute break, come back at 11:20, and we will finish up chapter 19 and get into chapter 20. All right? So 11:20, please. Okay, it's time to gather back again and finish up this chapter. We will go over hygiene, etc., in lab this week or next week. We're just going to hit the high points here. We've already talked about risk factors for impaired skin integrity. We will talk about bathing though. There are many things about bathing we need to know about. So our goals for hygiene, because we always have to have a plan, right? So the patient's skin integrity will be maintained, their hair is clean, their patient mouth is intact and free from odors. These are good goals that you can use for hygiene. These are also good things that you could document. Okay, these are good words for documentation as far as hygiene goes. Bathing has 4 purposes. You know, you're very familiar with the cleansing the skin type bathing, right? But there's also bathing to promote comfort, to stimulate circulation, and to remove waste products. When we give our patients a bath, we should not be trying to get the hottest water possible. Our water should be warm, but it should not be hot enough to burn the patient. Remember, a lot of your elderly patients have very thin skin and not much thermal regulation. So very hot water could actually cause burns, okay? Then you may either give a partial or a complete bath. And when partial, I'm not talking about we only wash part of the body. I'm talking the patient does as much as they possibly can, and then you do the rest. You are not completing a complete bed bath where you do all the work. So if your patient can wash their face and their hands and, you know, their upper body in the front, and you have to wash the back, then that's a partial bed bath. You did part of it and they did part of it. And whenever you're giving a bath, you want to provide for comfort, safety, and privacy. You want the room to be warm enough. You want them not to slip on a wet floor, okay? And we want them to be comfortable in that environment. So cleansing is the most common type of bath, done in the tub, the bed, or the shower. Always offer your patient the use of the toilet before bathing, okay? Those of you who are not in healthcare, I'm going to warn you right now that the minute you put people in that shower chair, the shower chair is shaped like a commode, okay? So they will generally void or defecate when they get in the shower chair, especially your confused patients. So it's always good to put them on the toilet before that, okay? Some patients need assistive devices like a chair or a stool to sit on while they're in the tub or in the shower. Others patients can't get to the chair in the shower room, so you have to use the shower chair to get them down there, or you'll transfer them into a shower chair. A therapeutic bath is going to have healing or medicinal qualities. So a whirlpool, basically a little hot tub, okay? It's going to cleanse and stimulate peripheral circulation, all right? We used to use whirlpool baths to clean out wounds, okay? Because the jets would get the dirt and the debris out of the wounds better. A sitz bath, those of you who've had babies may know what a sitz bath is. It's where you have, you're applying warm, moist heat to the perineal area, and you can use medication in that water to help relieve the pain, okay? And then a sponge bath. This is the type of bath that you're just going to wipe them down a little bit to get rid of, to cool down the skin, to decrease the fever. All right, so there we have our cleansing bath and our therapeutic bath. Have you ever heard of a bag bath? Anybody ever give one? You'll find these in some hospitals. It's a bag full of pre-moistened disposable washcloths. Okay, just like your baby wipes, basically. All right. You can heat them up in the microwave, or you can use them directly from the bag. And they have 5 or 6 different cloths, so you may use a different cloth for each body part, but you do not have to rinse these the soap from the cloth off, which is an advantage if you're trying to give a bad bath. And you don't have to go back and get water. You can just use this bag. The problem with this is that they cost a lot of money, so you're not going to see them in a whole lot of places. Older adults do not need a full bath every day. Remember, their skin is drier than normal because they've lost their sebaceous gland activity, and baths tend to dry out skin. Okay? So we don't want to give them a bath every day, not a complete bath. You want to wash the peri area, you want to wash the face, the hands, but not a complete bath every day. Okay? Make sure the bath area is warm and that you've provided adequate draping. Remember, they get colder faster. You want to use warm water, not hot water, to prevent burns. And then when we dry our patients, we're not rubbing them dry, we're patting them dry. Okay, you're just kind of absorbing the moisture off their skin. And then we'll put lotion on while they're still a little damp. That'll help keep some moisture in the skin. Okay. And you always want to make special care to prevent slips and falls. The floors are slippery in the shower rooms. We never want to use any bath oil in the shower room because that makes the floor very slippery. So yes, we want to be careful with them not to let them fall while they're in the shower room. A back massage is another way that we can provide comfort to our patients. It communicates caring. It fosters trust. And it gives you an opportunity to see what their backside looks like. Okay? But this is stimulating circulation in that area. If they've been laying on their back all day, if you give them a back rub before bed, it relaxes them. It stimulates the circulation in that area. It decreases the chance of skin breakdown. Should be performed with morning and bedtime care. I know everybody's very busy these days, and I think back rubs or back massages are a dying art. But if you could do them for your patients, they really appreciate them. Perineal care. This is washing the perineal area. Okay. Proper draping to promote comfort. Remember, we want them to be in probably the dorsal recumbent position so that we can get into the perineal area, make sure we've cleaned everything. We want to explain the procedure, reassure the patient, because to the patient, it may be a life-altering moment that somebody has to clean their perineum. Okay? Other patients are used to it. And it may be a life-altering moment for you because you've never done it before. Okay? We all need to be matter of fact. This is something you're going to do. You're going to do it a lot. Okay? Avoid any sexually suggestive conversations or actions. Don't make any comments about the appearance of the perineal area. Okay? Remain professional and dignified to reduce any embarrassment for your patient. Mouth care. This is important. I know you're going to get tested on this, okay? Mouth care for a conscious patient. We want the bed in Fowler's position, basically. You want to put a towel under their chin so that you keep it from getting all over their clothes. You give them their toothbrush with the toothpaste on it. And they either brush their teeth themselves or you brush the teeth for them if they can't do that. You're going to brush from the gum line down, okay? On every tooth. We're not going to go across. We're going up and down. We're going down, not up and down, because we don't want to push any bacteria up into the gums, okay? Then allow them to rinse their mouth and spit and give them a towel to wash their mouth off with. That is a conscious patient. This is what you generally get tested on. Mouth care for the unconscious patient, okay? You need to provide full mouth care at least every 8 hours on an unconscious patient, all right? The goal is to get rid of the mucus that builds up in their mouth, to moisturize, to get rid of the germs that cause halitosis and germs. Remember, they're breathing through their mouth. Then if you have any gunk in your mouth that is bacterial laden, they're breathing it right down into their lungs. So we want to make sure we keep their mouths clean, okay? So every 8 hours, you're gonna do the whole toothbrushing, flossing, moisturizing thing. You want the patient on their side, with maybe the head of the bed up a little bit. You may need to use suctioning to get the fluid out of the mouth because the patient can't swallow. Generally, when a patient is unconscious, they don't have a gag reflex. So we're going to try and avoid fluid going down into their lungs. Administering oral care to an unconscious patient is on page 311. Okay. So they're going to be on their side, or their head will be turned to the side. The head of the bed will be up slightly. You're going to brush their teeth and use suction to get the excess fluid out of their mouth. You want to make sure you get rid of all the crusty things, mucus that is in the mouth. And then every 2 hours around the clock, we want to swab their mouth with a moist toothette in order to keep their mouth moist and avoid the hardening of the mucus that's in their mouth. Okay. But remember, you got to have them on their side, head of the bed up slightly, and you're going to use suction to get rid of the excess fluid because they have no gag reflex. Dentures. Dentures have to be cleaned. If your patient doesn't do it, you need to do it. After every meal, they should be removed and rinsed because food gets up under the upper plate for sure, and some under the lower plate. Okay. Some patients may use adhesive for a better fit, but you should be at very least doing care morning and at bedtime. Brushing, combing hair, making their hair neat, presentable. All right. If they have mats or tangles, we never, ever, ever cut them out of hair. That's not our job. Our job is to try and get them out with alcohol or astringents or conditioner, something that's going to loosen up that tangle. And it's going to take you a while, but you'll probably get it out after, a couple of sessions. But do not cut out tangles or mats in hair. Shampooing, the purpose is to remove dirt, soil, blood, and solutions from the hair. It also stimulates circulation of the scalp, makes it easier to brush and comb their hair when it's clean. Okay, they have special devices you can use to do a shampoo in bed that basically, puts their hair in a tub or their head in a tub and it flows off the bed and doesn't get the bed all wet. Shaving, obviously removing hair from the surface of the skin. This could be the legs, the face, or the axilla. All right. Make sure you're using gentle, short strokes to shave your patients and that you always assess, this is very important, always assess whether the patient is on any anticoagulation medicine, such as heparin or Coumadin or any of the new ones, okay, before you shave them. Because if they are, you want to use an electric razor, all right? We do not want to, because when you shave, you have the possibility of micro cuts or small cuts that are going to bleed, and they'll bleed for a very long time. So please check before the patient gets a shave whether they should be using an electric razor or a safety razor. Nail care, obviously, it's your job to keep down the bioburden, so taking care of their nails is one of the ways to do that. Make sure you're soaking them in warm soapy water before you cut them because it'll make them easier to cut. Toenails, we use a toenail clipper to cut straight across to avoid ingrown toenails. But if your patient is a diabetic, we do not cut their toenails. Okay, LPNs are not allowed to cut diabetic toenails. Okay.
Why not?
Because diabetics have a hard time healing, and if you nip their toe, then they're going to have an open wound on their foot. So let others do that. Keeps you safe. Make sure you clean their glasses before you put them on their face. You know, if they can't see through their glasses are useless. You're going to start seeing a whole lot more patients with contacts. You need to learn how to remove those contact lenses, and you're always going to wash your hands and wear gloves to do that. Hard lenses, you kind of pop out. Soft lenses, you kind of have to peel off. All right. Clean them with the commercial prepared cleaning solution and put the lens in the right cup. If it's the left lens, it goes in the left cup. The right lens goes in the right cup, because some people have two different prescriptions on their contacts. So we need to make sure we have them in the right cups so that we're not confused in the morning. Sometimes you'll run into somebody with an artificial eye. Now, this is not like a whole globe that is inside their eye socket. Generally, which was really surprising to me, it's just like a cover on the outside of the eye socket. All right. So to pull it down, you're going to pull down the lower eyelid and just put a little pressure below the eye and it'll pop off. There's many YouTube videos on how to do this. They have videos of 3-year-olds doing this, so it's not hard. Okay. You're going to make sure you catch it so it doesn't break, because these are glass. Okay. Cleanse them with normal saline and put them back in. Hearing aids. You can wipe off the earpiece, the outside, with, you know, a damp cloth to prevent buildup in wax and debris, but we are never going to submerge a hearing aid. We are never going to stick a pin down that little tube that goes into their ear. If the hearing aid is not working, make sure it's turned on, first of all. Make sure the battery is good, okay? And that there's no cracks and bases in the housing. Anything past being turned on and the battery installed correctly, you have to send it out to get fixed. So we've done all this hygiene and positioning and, you know, transfers, okay? We have to evaluate our care. Did we meet our goals? All right. So some of your evaluations, documentation, these are great lines to use in documentation, guys, okay? Patient has no evidence of redness, irritation, or breaks in the skin integrity is maintained. That goes back to your at risk for impaired skin integrity, right? Hair is clean and neatly styled each day per patient preference. The mucous membranes are pink and moist without signs and symptoms of irritation or odor. Those are fantastic documentation lines. You can steal them, okay? Because we have to document whether our care has been appropriate and that our goals are being met. So which of the following is not one of the basic purposes of bathing?
3.
Right, it's not to stimulate conversation. Nobody wants to talk while they're getting a bath, okay? And then which of the following is true regarding mouth care? True regarding mouth care. I see some 3s in the chats. See a 4, another 3. Okay. So we're looking for what's true. Number 3 says when assisting a conscious patient with mouth care, you should raise the head of the bed 15 to 30 degrees. For a conscious patient, is that correct? Or do we want them up higher?
Higher.
It's
We want
45
them
pin
higher.
9.
Right, so that's not correct. Dentures should be kept in a labeled denture container with saline or water when not in the patient's mouth. Is that true?
Yes.
Yeah, we need to keep them in some kind of liquid when they're not in the mouth. Okay, so we put them in a denture container with their name on it so we don't lose them. Okay, so number 4 is true. Okay, number 3 is not true because this is a conscious patient they're talking about. All right. So let's run into chapter 20 very quickly because I only have 20 minutes. The big part about chapter 20 is patient safety. Don't forget that Florence Nightingale was the big champion of the environment. Okay, so you need to know about the proper room temperatures and ventilation, humidity, and lighting. Those are all in your book. So I'm not going to spend a whole lot of time on that. So we know things that affect your environment: the temperature, ventilation, lighting, noise, odor, interior design, how neat is your environment, what's your privacy factor. Those are all things as a nurse, you're thinking, oh God, I got all these other things to worry about. No, you got to worry about the environment too. All right. So these are what you are going to look up yourself. Just remember that temperature needs to be warmer for babies and for older people because they don't have good temperature control. Odor. To control odors, make sure you get rid of the stinky stuff. Empty the bedpans and rinse them. Bedside commodes, urinals, don't let that sit in there and stink. All right. Make sure they dispose of the Depends in the trash can and then take the trash out of the room. Okay. So that the room doesn't smell like a dirty Depends. Okay. You can tell how good a nursing facility is when you walk into it and you don't smell urine. Okay. I've walked into some pretty nasty places. But if it just take a few minutes every day to get rid of the stinky stuff, your environment will smell better. You'll get a much better impression from the public. Okay. Removing old flowers and stagnant water. A lot of times they don't want you to get rid of that bouquet from Johnny. That's fine, but you got to get rid of the water. Okay. Either change the water or get rid of the mold in the vase and put the flowers back in. All right. Perfumes, scented lotions, and scented cosmetics should not be worn in patient areas because they tend to make people who are on the brink of nauseous. They can affect people who have asthma or respiratory issues. So we really should not be using the scented perfumes and lotions before we go to work. Noise. The main source of noise in healthcare is people. People being you guys working. Okay. Patients hear things, they're hypersensitive. They hear everything you say in the hallway. Okay. If they get sensory overload from all the noise that's around them, if it's in a busy ICU type unit or a busy med surg unit, and the noise is not controlled, your patients may get sensory overload, and then you're going to have confusion and delirium and all kinds of fun stuff like that. So we want to reduce noise by avoiding long conversations in the hallway. And remember HIPAA, we shouldn't be talking about patients in the hallway anyhow. Encourage the staff to speak in lowered voices. Remind them that it may be their daytime if they work 11 to 7, but it is not your patient's daytime. They need to keep their voices down. Avoid jokes and laughter at the nurses' station. I used to get reports every Monday morning of parties going on at the nurses' station. Because we had a crew, nursing staff that came in for just the weekends and they wouldn't see each other for, 5 days. And so they'd all be very happy to see each other and catching up with each other. And it just sounded like a party to the residents. Okay, make sure you answer alarms on pumps and equipment promptly so that the whole unit is not listening to beep, 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 beep. Not fun. All right, our patient rooms now are starting to look more like hotel rooms as opposed to what they looked like in the past. Okay, This is for comfort in a home-like environment for the patient. We just have to remember to keep them neat and clean. And then privacy is always essential. It reduces stress on your patient. It's essential for their well-being. Make sure you knock and identify yourself before you enter the room, that you close the curtain around the bed, that patients are provided privacy for all procedures and treatments that you do. And if you're doing something that's going to take a long time, if you're doing a large dressing change, or if you're doing a bath, make sure that there's something on the door that says, hey, we're working here. Come back later. So people don't walk in on them. Sometimes, you're going to have to make beds. There are 2 ways to make a bed. When a bed is unoccupied, you should have it made. It should be straightened up and neat. Okay. So if the patient is in the chair or out of the room, we need to make the bed. There's a specific direction on how to make an occupied bed, which you will be doing in lab. And you can do that. You only do that if the patient absolutely cannot get out of bed. Okay. If they can get up and sit in a chair, that's where they should be while you're making the bed. And make sure your linens are neat, orderly, and free from wrinkles, because wrinkles can cause pressure areas. All right. Safety is your primary concern, okay? You want to prevent accidents for your patients, you want to prevent accidents for their visitors, and you want to prevent accidents for the healthcare personnel. Common accidents: falls, burns, cuts, bruises, fights. Okay, these are things that are very common in any healthcare environment. You'll need to look at box 20-3 for ways to promote safety. And they're basically common sense stuff. It's on page 330. Okay. Make sure we look at their patient drug regime to make sure they're safe to be up on their own. To assess their gait and their risk of falling on admission, to get some night lights in the room to aid in patient getting up at night, to decrease disorientation. Let the patient know when you're planning on checking in next, because then they'll be less likely to get out of bed. And then the safety for the home is another thing that you need to worry about if you're sending your patient home. 3 common factors in a fall: impaired physical mobility, altered mental status, and sensory or motor deficits. 3 things that inevitably people with these conditions will end up on the floor. Okay. I do not agree with the use of leg or bed alarms in general. If you have a patient that you've tried everything else on, fine. But you shouldn't have more than 1 or 2 alarms on a unit, because if 5 alarms are going off, where are you going to go? You don't know where to go, right? I'm sure some of you experienced that. Try everything else before. Think outside the box before we put an alarm on a patient. All right? Alarms just notify you that they're on the move. It does not tell you, it does not keep them from falling on the floor. A lot of times the alarm is what tells you that they're on the floor. Okay? So think outside the box before we get into the alarm phase. Burns. I've seen burns from hot coffee in the dining room. Okay? Make sure we're aware of the temperature of what the liquid is we're giving them. Some of those coffees that come out of the canisters or the carafes are very, very, very hot. And remember, your patient's skin's thinner and much more likely to burn. I've seen 2nd-degree burns caused by coffee. Okay? So you always check the liquid. We want to caution the patient about sleeping on a heating pad or a cold pack, especially if they have any kind of sensory deficit, because they're not going to be aware that they're being burned. Okay? Inspect electrical cords for frayed or broken areas that can cause sparks or fire and electrocute your patient or give you the shock of your life. There's not a whole lot of smoking going on in health facilities these days. There are still some long-term cares that allow it based on, the patient was there before the law. But make sure we're supervising patients who are sedated confused, irrational, okay? That they're not burning themselves or burning the house down while they're doing it. We never allow smoking around oxygen because oxygen makes the flame bigger. It doesn't start the fire, it feeds the fire. So you could have your little, you know, portable or disposable lighter and they flick it and it's usually only a flame about this big. But if there's oxygen involved, it's going to expand and it's going to cover their whole face. So it's not a good thing. Okay, who knows what race means? I'm sure you've heard this at work. What's race?
Pull and squeeze and sweep.
No, that's pass. That's using a fire extinguisher. What's race?
Oh, rescue.
Rescue.
Alarm. Alarm.
Activate the alarm.
Confine
Confine or contain
Contain.
the fire.
and evacuate.
Extinguish.
Evacuate or extinguish, depending on where you work, okay? If the fire is small enough, like a trash can fire, and you got a fire extinguisher close by, you can go ahead and try and extinguish that fire with the fire extinguisher, okay? If it's involving more than a trash can, you just close the door and let the fire department handle it. Okay, all the doors in healthcare are fire resistant for up to 2 hours. So you can close the door, it's not gonna go anywhere else out of that room, okay? All right, things that we do to promote safety, make sure we're orienting our patient to the unit and to their room on admission. Make sure we assess their gait. We evaluate their drug regime. We keep the bed in lowest position when not giving direct care. And if you look on page 220 or 330, you are going to see toilet the patient on a regular schedule to decrease the chance that the patient will try to get out of bed unassisted is in bold, meaning that's the #1 way we can prevent falls. Because the reason they're falling is they're trying to get to the bathroom, okay? So toilet that patient on a regular basis. Make sure you're locking the wheels, getting night lights, encouraging the use of non-skid slippers, answering call lights promptly. Tell the patient when you're going to check in again. These are all on page 330. Okay, you can actually move patients around on the unit to get high fall risk closer to the nurse's station. So there are more eyeballs walking by the room so more people can keep an eye on them. Biohazards, this is bioterrorism, chemical terrorism, or radioactive substances like a dirty bomb. Okay, these are usually compounds put out there to achieve political and or military goals. Okay, in these times, we need to know this stuff. All right, diseases that spread through bioterrorism. Anthrax, botulism, Ebola, Lassa fever, plague, ricin, smallpox, and tularemia. Okay, these are things that can be aerosoled or put into water to get a large population sick. So whenever we are coming in contact with these chemicals or these bioterrorism pathogens, we want to make sure that we are wearing very high level protective equipment. Okay, masks with filtered respirators worn with the suit. One of the first steps if somebody has been contaminated with a chemical is we want to wash them down to get the chemical off of them so we can decontaminate them, take all their clothes, all of that. And then in any kind of major disaster, we're going to triage the patients and determine the treatment level, okay? If they are at immediate risk for dying, okay, from airway issue, head trauma, bleeding, they will be immediate care. If they have maybe a broken bone that can wait an hour, then they will be delayed. Minimal would be people you could probably just send home. They just have cuts and bruises. And then expected means that they're expected to die and we're not going to put them on a treatment plan because we're not going to waste resources on somebody who's not going to make it anyhow. Unfortunately, that's the reality of the situation when we're triaging in a disaster. Okay, depending on what you're exposed to, it may get antibiotics or antidotes, okay? Or we'll just direct treatment at supporting organ function while the body tries to recover on its own. Poisons. Anytime your patient comes in contact with the poison, ingests the poison, etc., first thing you're going to do is call the Poison Control Center, no matter what type of facility you're working in. They have all the information at their fingertips, okay? And they can give it to you quickly, all right? The other thing with chemicals is you're going to have a material data safety sheet for every chemical that's in the facility. You can look up the chemical to see what to do to clean it up, to what to do if it gets ingested, etc. All right, this is what I really wanted to get to when I got 4 minutes. Okay, protective devices are restraints, okay? In psychiatric settings, behavioral indications, sudden change in mental status, these are appropriate. And non-behavioral indications would be continuation of medical treatment. If they keep pulling out IV lines, they're confused, they can't keep, they're not, you know, they keep pulling at their tubes, their endotrach tubes and things like that. So it is your responsibility to be aware of and follow the regulations in your facility. All protective devices need to have a physician order. Okay, we should try and protect our patients from physical restraints or chemical restraints. Okay, and then that order is only for a specific period of time for a specific restraint. Okay, not something you can just decide to do and then call the doctor in the morning. We try to find an alternative to protective devices. Our goal is to have the least restrictive environment possible for our patients. So find something that they can do to distract them, or get somebody to sit with the patients who's confused, family, friends, some hospitals have sitters, okay? So that we can get that medication or we can get that treatment done without having to restrain your patient. We want to use the least amount of immobilization needed. So if it's for pulling out an IV, we only want to restrain the opposite hand, okay? So they can't reach over. As soon as the device is no longer needed, the physician must be notified to DC the device. You're going to apply it snugly, but you should be able to get 2 fingers underneath the device so that we're not cutting off circulation. The device must be removed and the patient's position changed every 2 hours. This is law. Every order you have for a protective device should include checking and removing the restraint every 2 hours and checking on your patient every 30 minutes. The 30 minutes is a safety check to make sure they're not doing something like trying to get out of the restraint and strangling themselves in the process, okay? All right, 11:59, I made it. This is recorded, guys, so it'll be out on YouTube shortly, probably by Wednesday. So that if you want to listen to it, I know I went really fast in a lot of things, you can listen to it again. You also have 3 different PowerPoints in your readings about hygiene, pressure ulcer care, and safe patient handling that are actually from your Saunders books. And they're very detailed on how to do this stuff. When we come to when we work on lab, we will be working on hygiene, giving bed baths, transferring patients and stuff, which you will practice again when you come to school the following week. Okay? So those of you who need to take exam 1 need to get hold of me, send me an email and tell me when you're coming in. I sent you an email the other day. I need to know when you're coming and it has to be done by Friday or you're not going to have the opportunity to take this exam. Okay, so DeConte Vanessa. I don't think the other people are here. Meninatu, Mariama, and Jasmine. If you guys know them, push them a little bit to get their exam done, okay? So we have to have this done, so I can get all those grades done, all right? Before exam 2, which is next Tuesday. Exam 2, chapters 4, 5, 6, 7, 8, 18, 19, 20, 21, and 22. It sounds like a lot of chapters, but look, you can chunk it. We have care plans, 4, 5, 6. We have documentation and communication, 7, 8. We have health assessment, vital signs, that's 21, 22. And 18, 19, and 20 is all the safety stuff we went over this week. Okay? Don't forget there are reviews online and in person that you are more than welcome to attend. We also have study tips Wednesday night at 6 p.m. with Ms. Burton. Or any of you want to go to the test taking tip workshop with Dr. Doan, who is amazing. Okay, that's Saturday morning at 8 a.m. And all those Zoom links are on the flyer that's posted on your homepage in Canvas. All right, I will see you guys. Those of you coming to the lab, I'll see you in an hour. All right. So the rest of you I'll see on Thursday. Have a good day. Stay safe out there.
Too. Thank you.
You're welcome. Minatu, you are there.
Prof, I do have a question.
Yes, Charles.
Okay, with the just ended quiz, I just checked it and it says I'm late in there.
The quiz?
Yeah, no, I didn't miss the quiz, but then, you know, there's an indication that probably I didn't submit it on time, but I did submit it before, I think 10 minutes to
Okay.
time.
I'll look.
Okay.
I'll be fine. Thank you.